Hi, this is Dr. John Bennett from Lisbon, Portugal, broadcasting another in the AFAN series, Ulrich Sydney. He's going to talk about taking care of the comatose patient tonight. First, we'll introduce a few of the panelists that are here now. Zolo, can you say hello, please? Can you hear me, Zolo? There he is. Go ahead, Zolo.
Hello, everyone. Hello. Yes, I'm having some issues with my. Anyway, I'm Zolo Ivan. I'm a CTA medical student from the University of Buea in Cameroon. Happy to be here.
Very good. Thanks for coming, Zolo. Khalif, could you please introduce yourself? Let me unmute you there. Go ahead, Khalif. Are you there? Did you step away? I guess he must have stepped away. Okay, Ulrich, it's all yours.
Thanks, John. Thanks. So, hello, everyone. I'm Ulrich Sydney. I'm a research associate at the program in global surgery and social change at Harvard Medical School. Today, we're going to start a new lecture series by the Association of Future African Neurosurgeons. And our lecture series will be on neurosurgical emergencies. First, in a lecture series will be the clinical evaluation of comatose patients. So, this is the plan we'll be following. So
it's fine.
Yeah, so we started with a brief definition of coma in itself. So there are a few definitions of coma out there, and here are a couple. So coma is an extreme state of unconsciousness with an apparently sleeping patient or unresponsive to even painful stimuli. So another explanation goes through the relative loss in the life of relations, being able to interact with the external environment while conserving a part of the vegetative functions. We'll talk more about this later on. So usually this would mean there's a lesion to the structures that are in charge of being alert and being conscious, and these structures are grouped under the term ascending reticular activating system. So the ascending reticular activating system, or RS, so it's actually part of the reticular system, and it's an ensemble of nuclei around the brainstem from the tegmentum all the way down to medulla oblongata. So the reticular formation itself is actually could be divided into two. You've got ascending pathways and descending pathways. And what we're trying to talk about here is the ascending pathways. That is all this ensemble of nuclei at the level of the brainstem going all the way to the cortex. So the reticular formation in this case, like we said, the part of the reticular formation that's in charge of alertness, consciousness, sense of awareness, that is the ARAS. So, like we described, the ARAS has multiple nuclei, and these multiple nuclei equally interact via multiple neurotransmitters. This is just a diagram of the very some of those neurotransmitters and nuclei. So what we see here is, obviously we see the ascending pathway coming from the brainstem here all the way to going to the cortex, and we can see from this diagram that we have nuclei that secrete noradrenaline, like the locus coeruleus. We have serotonin, like the raphe nuclei, that's the dorsal and median raphe nuclei. Here, histamine as in, we saw this last week with the hypothalamic nuclei, and here, this is actually the mammillary, tuberomammillary nuclei. Acetylcholine as well, GABA, Here we have creatine, the hypocreatine, a neurotransmitter, dopamine as well. So the ARAS extends, like we said, from the tegmentum all the way to the thalamic, intralaminar nuclei, and basal forebrain. Some of these we already saw. We saw that we've got so many neurotransmitters and we've got corresponding nuclei. So the functions are consciousness, regulating the sleep-wake transitions, attention. And this brings about understanding what is arousal, what is consciousness. We should be able to define this, because then we'll be able to make the difference between what is a coma and what is not a coma. So arousal is the physiological and psychological state of being awoken. It is very, very important in regulating how conscious we are, a sense of attention, alertness, and information processing. What this means really is, this is what makes us be able to interact with our surrounding. And one of the major ways we interact with the surrounding is via stimuli, being able to perceive external stimuli. This might be auditory, this might be olfactory, this might be through a sense of touch or sight. And then we as well can interact. We as well can interact with this exterior via other mechanisms, like it might be more conscious in the sense of cognitive memory, or being able to speak, being able to act or have emotions. These all find themselves in this bigger ensemble, this bigger concept. Equally, it's important in motivating certain behaviors, such as mobility, fight or flight. So, yeah. So consciousness is the state or quality of sentience or awareness of internal or external existence. So once we say this, we're confronted with the definition of all the different alterations of consciousness. And that's why we can say there's a continuum in these different states. We have things like obnubilation, delirium, confusion, loss of meaningful communication, or not being able to respond to nociception. And then we come up with, how can we evaluate this consciousness? And the oldest and standard method is the Glasgow Coma scale. So most of us here are familiar with the Glasgow Coma scale, but we can just come up with just a few maybe reminders. And the few reminders we need to think about is, we're talking about best responses in every single case, be it the eye, verbal, or motor. And remembering this very simple concept helps have being able to distinguish between certain situations. So say a patient is hemiplegic and you decide to go and stimulate this patient on that hemiplegic side, and that side doesn't move, and you start thinking, well, what do I do in terms of motor response? Do I just think about the other side that was moving? Do I think about this side? So such a question stems from the fact that you need to understand, or you probably didn't really understand the difference between the concept of consciousness and elements of motricity, in the sense that if you're thinking about the strength of a motor response, then you're not talking about consciousness. You're already evaluating a different concept. So like we defined, we're trying to see if there's that volitional control, that is the impetus to move, and that volitional control will be manifested through a best motor response. So you don't have to find yourself worrying about a side, for example, that's hemiplegic, or limbs that are paraplegic, because there's actually volitional control on the other side. So keep the best response. Then when we talk about the Glasgow Coma scale, there reaches levels at which the Glasgow Coma scale is not in itself enough. So some have called this Glasgow Liège Coma scale, but others will just speak about the brainstem reflexes. So when you find yourself with a very low Glasgow Coma scale, then you have to go further and find out how much of the brainstem is actually left in terms of the reflexes. And these reflexes, there's so many of them. We know some, and we check for some clinically. Usually that's the oculocephalic or oculogyric reflexes, be it horizontal or vertical, corneal reflex, photomotor reflex, oculocardiac reflex. So talking about the oculocephalic reflex, the concept of doll's eyes. So a rotation of the head here, we've rotated the head to the left. We see the eyes rotating in the other direction, that's to the right. So they're trying to sort of keep themselves aligned, the alignment they had. And this is due to a connection between, on the one part, the oculomotor nerves, the vestibulocochlear system, mostly the cochlear system, and as well as the brainstem. And that's how they get information and feedback. So from the cochlear system, information is given when there's a movement of the head in this direction. And so there's a feedback mechanism that instructs the oculomotor nerves to get the eyes in the other direction to stay aligned. And this is horizontal. You can have the same thing vertically. When you talk about caloric responses, this is about injecting. You can have a cold or a hot test. So here we have a cold test, obviously, because it's 0 degrees Celsius. And you get a reaction, which is when it's normal. In the cold reaction, the eyes look in the direction of the stimulus. Here we have an asymmetric response. Clearly, we can see that there's one of the eyes that's reacting and the other isn't, and a negative response when both don't move. So we spoke about consciousness and spoke about awareness and alertness. Then the next question that comes to mind is, so what is a coma and what is not a coma? This is very important, and a few terms that might be misconstrued as being a coma are on this table. The locked-in syndrome, for example. So a patient with locked-in syndrome is this patient that's actually aware, conscious, has volitional control, but is not able to do most of these movements. And so this is the kind of patient that might be able to do eye movements or be able to move their palpebrae, and so might communicate that way. And this is very, very different, and it's actually even called the pseudocoma. It's very different from a coma. So another state is the minimally conscious state. So the minimally conscious state, it's a patient who finds himself sometimes being aware or awake, and then sometimes they're out, sometimes in, sometimes out. So you have that variation. What was previously called a persistent vegetative state is now called an unresponsive wakefulness syndrome. And these are sleep-wake cycles that the patient has, and the patient lacks awareness, but he displays reflexes and non-purposeful behavior. And then all other ones are the brain death and chronic coma. So what is noteworthy here is for the unresponsive wakefulness syndrome and for the minimally conscious state, the most common causes are usually in terms of blood flow, blood circulation. So you're going to see cardiac arrest for the cardiac part of it, and for the vascular part is the cerebral hypoperfusion. So these are the most common causes of these two states. And as we'll see later on, this is not the case for coma. We'll see all the different things that can cause a coma. So less profound than a coma, but still neurological at these other states, stupor and drowsiness. This actually is very easy to distinguish from the standard definition of a coma. So a patient who is in stupor is a patient who's who can still be stimulated with nociception, so he can be awakened by nociception. A patient who's drowsy, we all think about sleep. So it's mostly a patient that looks and feels very sleepy. So it simulates light sleep. So stupor and drowsiness are usually accompanied by some degree of confusion. And in terms of confusion, we neurologically, we have, we try and find if a patient has, it can be defined as a patient having hazy thoughts. So the line of thought or the process of thinking is not that clear, it's not that obvious. And this patient might actually have problems with their orientation, might be disoriented as well. So this gives you an orientation towards stupor and drowsiness. Everything is not always neurological or neurosurgical. So you have to think equally about the more neuropsychologic states. And one of them is abulia. Abulia in itself is not really a difficulty to, it's not very difficult to distinguish from coma. But when you have the severe form of abulia, that's an akinetic mutism, then you might confuse it for a coma. So a patient with akinetic mutism is partially or fully awake, and these are patients who are virtually immobile and mute. They don't communicate with the exterior, and usually here we have injury to the medial thalamic nuclei or the frontal lobes. In terms of another state that is important, noteworthy, is catatonia. It's just a patient that doesn't move that much and is equally mute. And in this case, in catatonia, it's usually associated with like schizophrenia. So patients who have this dissociation of their psyche have a phase usually during which they don't move. Like they can hold a position, certain positions for very, very long. It's incredible. And this, again, should be differentiated from a coma. So things that can help here is the fact that they're actually able to blink and swallow. So obviously you're not looking at a coma. The more interesting part now is the classical clinical examination. We already know the states: history, general physical, neurologic, and level of arousal. Why come back to this? Coma is sort of an end state of a variety of diseases, of disease processes in neurology and neurosurgery. And being able to know what caused the coma comes back to doing a really thorough and detailed clinical examination. So it boils down to this: your line of treatment, your management and treatment will be very dependent on what you find as the cause of your coma. And so there's two mnemonic techniques here. Choose anyone and stick to it. So you can use this, you can use this other one. Still, you have to consider all these various causes. So for metabolic, you can think about PEGs as well: CO2, O2, ammonia, temperature, pH, electrolytes, glucose, serum osmolality. And the obvious question that will come to mind is, coma is an emergency. Do I have time to think about all these things at once? Do I go run through them all at once? No. So what do you do? How do you manage to narrow these things down? Well, to be able to narrow these things down, then you should be able to have in mind, again, during the clinical examination first step, history. During the history, what are those things you're looking for when you're told by someone who was with the patient or who knows about the patient's state before they found themselves in a coma? What are you looking for to know, to have a better idea about this? So here, vascular. what can cause a coma? Well, subarachnoid hemorrhage, for example. So if you're thinking subarachnoid hemorrhage, classically, you'll be looking for things like that headache that is usually described as the worst headache in one's life. That's been described as well as sort of a thunder storm or lightning in a very serene sky. So it's a patient that was okay and had this really terrible headache. So that can give you as an idea that, oh, maybe we're thinking maybe we have a subarachnoid hemorrhage here. If obviously you can get that in a history, and that means you should be able to ask those questions as well. If you're thinking infectious, then you probably say, well, was there any history of fever, or is there a state that could expose the patient to infections, anything that is immunosuppressive or immunodepressive. Neoplastic, I mean, once again, this is wide, but you would think, okay, neoplastic, it takes a bit of a while to constitute itself. So what you'll be looking for is signs of localization and generalization. Localization, that's pretty vague. If it's frontal, you're looking for frontal syndrome. If it's temporal, and you look for temporal. But generalization, you're thinking more signs of raised intracranial pressure. So the classical ones, you're looking for those headaches that were progressively increasing, that at the beginning might have been amended by acetaminophen, for example, but then got worse. And then when the patient was coughing, it was worse. And usually it could be during the morning, the patient was vomiting, it was incoercible. The patient equally might have described diplopia. The patient might have described visual blur. So these things say, okay, it's been over the last 2-3 months, 6 months. Okay, maybe we have a neoplasm here. Another thing would be the patient has a history of already having a cancer that sends meds to the brain. So we know the classic ones. We know there's the breast, the lungs. You're equally looking at renal cancer, melanoma, colon cancer. So you have to ask those questions real quickly. If you're thinking trauma, for example, then obviously you're looking for that story of the patient falling, maybe, or maybe the patient was found at the bottom of a staircase. So if you're told by the emergency team or the person who brought the patient, well, we found him at the bottom of a ladder, we found him at the bottom of a staircase, you have to ask that question. So if the patient finds themselves with like lacerations on the scalp, for example, that doesn't say automatically it's a trauma. The patient might have had something else, but at least it gives you that orientation. Or the patient might have other lesions other than cranioencephalic. So a patient who has a fracture on maybe the wrist, a wrist fracture, has another, a femur fracture, then you think, well, it's possible that this patient actually fell and it might be due to trauma. Endocrine, same thing. You have to think about all those different diseases that might alter the patient's blood pressure. It's very important. You have to think about blood pressure. You have to think about the ions as well. Sodium, think about that. So that means things like Addison's, things like Cushing's. You have to keep that in mind. Metabolic, like we said, Codepex. So once again, you can add here, you can add toxic as well. So you have to be looking at that. When we say toxic, then you're thinking, did a patient maybe, what was a patient taking drugs, sort of like amphetamines maybe? Was a patient taking more class like medical drugs as well? Anti-epileptic drugs. Modifications of anti-epileptic drugs dosage might explain alteration in consciousness, not all the way to coma perhaps, but at least they give you an indication of what might have happened. So you need to ask those questions and you need to find that really quickly, because again, this is an emergency. And it's important because the treatment you're going to put in place for vascular cause to a coma will not be the same that you're going to put in place for an infectious cause for a coma. So this is very, very large, very huge, because we're talking about a coma. A coma is a neurological manifestation, but that doesn't mean everything that's a coma is neurological in terms of the etiology or is neurosurgical. So you want to make sure that you have the right etiology. And now, if you're thinking neurosurgically, if this is a neurosurgical lesion, then you're looking for things like, if you have unconsciousness, if you have a trouble of consciousness, then you'll be thinking, can you please, there's someone who needs to mute. Andre, can you please mute yourself? So large structural lesions directly interrupting the ascending reticular system, that will cause troubles in consciousness. Unilateral hemispheric lesions do not cause this unless, for example, by a means of like compression, so by increased intracranial pressure. Then you have other things that might give you an idea of where this lesion might be. So these are a few. If it's hemispheric, if it's subcortical, so you're thinking, oh, maybe we have a lesion that's at the level of the midbrain or pontine. So you know those classic things you're looking for. So if you're thinking midbrain, think about cranial, anywhere around the brainstem, think about things like the cranial nerve pulses, and we know approximately where these cranial nerves are and what lesions at that level should cause. So if you're thinking medulla oblongata, then you're thinking, oh, is it 9, 10, 11, or 12, maybe? But also other functions of the medulla oblongata. If it's midbrain, you're thinking, well, is it the 3 and 4? But be careful, because in the case of strabismus or diplopia, the patient could tell you, but it would be strabismus in this case. Well, a lesion within the brain through raised intracranial pressure can cause compression of certain cranial nerves. And that will not be due to a direct compression by the lesion, but rather by the raised intracranial pressure. So it's not very uncommon. It's not very uncommon to have like seat or the third or seat pair of cranial nerve palsy due to raised intracranial pressure. That doesn't mean necessarily that the lesion is directly on the part of cranial nerve 3, for example. So you want to be, you want to think about that when you're trying to find the cause of this lesion. So talking about cranial nerve 3, like we all know, we have one nucleus for the parasympathetic, that's the Edinger-Westphal nucleus, for like the intrinsic motricity of the eyeball, and for the extrinsic motricity of the eyeball, we have the oculomotor. That's superior, internal, inferior, and small oblique. Now, talking about the intrinsic oculomotricity, then you're thinking about, is it miosis or mydriasis? So when you keep that in mind, then you can have pupils that are said to be small, fixed, or they can be said to be dilated, they can be said to be pinpoint, and you have these different appearances here, which means doing a proper clinical examination in the sense that you have to measure your pupils' diameter. You have to compare them bilaterally, and you need to remind, very important, you need to remember that shining a light source into one eyeball should normally give you the same reaction on both sides. That is a reduction in the diameter of both pupils. Now, once you keep that in mind, you would understand why being able, for example, to shine a light in the eyeball on the right, getting a reaction on the left and not on the right, is very different from being able to shine a light, say, on the right, having no reaction, going to the left and having a reaction on the right. That's very different, because you need to keep in mind the different pathways. So as a reminder, once again, it's not that you can have a standard examination of coma, because the causes of a coma are so diverse. So you need to be able to, from the get-go, from the history, to really narrow down things to be able to actually get to the root cause of your coma. And you need to be not typical in like you only think about three things that can cause a coma. You really need to go out there from the get-go and try to reduce the probabilities as much as possible. So now you know it's a coma. What do you do? Well, the first thing you need to keep in mind is, what is your goal? You want to reduce the extent of the nervous damage. You want to reduce that. What does that mean? It means ABCs. So real quickly, airways, breathing, circulation. In terms of breathing, you can actually get information about what the lesion might be, or the lesions might be. So always remember, there's all the forms like respiration said to be cinemateria. So respirations like a Kussmaul respiration, that gives you an orientation. If you see ataxic respiration, that gives you an idea as well. Or a Cheyne-Stokes type of respiration, it gives you an orientation. So if you see a Cheyne-Stokes, for example, you could be thinking, well, a lesion at the level of the brainstem probably could be, if it was sudden, you can say, oh, vascular, so maybe a stroke. Yeah, that's okay. If you think Kussmaul, then you're thinking something might be, there's some acidosis here, so probably metabolic, and that gives you an idea as well. In terms of circulation, cardiovascular, the blood pressure, is it high or is it low? Like we said before, states of hypoperfusion. So a low blood pressure gives you an idea, like, okay, states of hypoperfusion, this is what I can think about. High blood pressure, well, in terms of neurosurgery, we know about the Cushing's reflex. High blood pressure, bradycardia, hypoventilation. So something's wrong, and now the brain is not compensating anymore, so you have Cushing's reflex. Because you remember, the blood supply and therefore vasomotricity at the level of the brain is not regulated like the rest of the body. At the level of the rest of the body, what you get is inputs through the sympathetic receptors at the level of the muscles to determine whether there's contraction, so vasoconstriction or dilatation. Now, if you're at the level, when you're at the level of the brain, the principal driver of motricity is CO2. So anytime you get an increase in your CO2, you're going to get vasodilatation. And if you remember the doctrine of Kelly-Monroe, you have to have, normally you're supposed to have a correspondence between the contents of the cranium and the cranium itself. So an increase in any compartment has normally to be compensated by another compartment. So usually what happens is, if you increase something in the parenchyma, then you should have vasoconstriction to decrease the amount of blood at the level of the vessels, or you should have a shift of CSF. Now, when this happens for a long while and the brain is not able to compensate anymore, then you have an increase in CO2 and acidity. So you have a vasodilatation, and that becomes reducible because you have an increase in the amount of blood flow. So an increase in intracranial pressure. Other things you need to keep in mind are those lesions that were not caused by the etiology, but that will be caused by systemic reactions or disturbances. So things like hypoglycemia, hyponatremia, pain as well. So hypoxemia, for example. So you need your patient to be well ventilated. You need to control their blood glucose levels. You need to control their ions, especially sodium. You need to make sure they're not feeling pain for whatever reason it is, so that you reduce as much as possible the lesions to the central nervous system. Now, these are not specifically directed towards the etiology of the coma. This is what you do to limit the lesions. But then for you to go on to tackle the etiology, then you should have carried out a good examination of your patient. You should have taken the history as much as you can and really looked for any signs towards the etiology. And we said these things could be neurological, neurosurgical, or neither neurological or neurosurgical. anyway, if you think it's is due to an intoxication, maybe morphine, okay, antidotes like naloxone. If you think your patient is hypoglycemic, dextrose. If you think you have a patient who is hypoglycemic and is a heavy alcohol consumer, so chronic alcoholism, then think about thiamine. If you have benzodiazepines, maybe flumazenil. This is an anticholinesterase. So in a case in which you have you're trying to reverse the cholinergic effects. If your patient has an acute stroke, ischemic stroke, think about the time window. When was the patient last seen to be well? And can you apply any of these treatments? Once again, time. Be careful with the solutions you're giving the patient, especially in terms of like hypotonic solutions, because hypotonic solutions, very few NaCl or very few glucose, a lot of free water, and this free water is going to move right through the phenomenon of osmosis, and this free water moving will cause swelling of brain cells, which is the definition of brain edema. So you're going to increase brain edema. So be careful with your administration of hypotonic solution. So another caution about management, what you need to do. So if you're thinking there's a trauma, history of trauma here, well, if you're thinking there's already brain trauma, then assume there's spine trauma as well. Assume there's spine trauma. So thinking about that means that if you're trying to secure the ABCs, the airways, for example, be careful with the way you handle the cervical spine, because you might make the lesions worse. And don't forget, the cervical spine might actually give you situations of altered mental status as well. So keep that in mind. If you're thinking it's infectious, then be careful and be careful with what you administer to the patient in terms of antimicrobial drugs. Always remember to get the blood cultures before you give your antibiotics, because that's actually what's going to give you the results. You want to get the best results. Monitoring. Now, in the best case scenario, you should be able to have all of this or most of this. Like we know in our context, and we are the Association of Future African Neurosurgeons, so we have to speak about this. In our context, it's not always possible to have invasive monitoring, brain monitoring for our patients. It's not always possible. So you need to be able to monitor these patients with non-invasive methods. For us, it starts with the really simple ones, like just clinical monitoring, and that might go further with things like maybe using an ultrasound for the diameter of the pupil, or equally, if you're lucky enough, you can get these ICP monitors, and if you have the brain tissue oxygen probe, then go ahead. Well, if you have ICP that's high, what do you do? So the simplest thing is get your patient to be proclave 30 degrees. You might be able to drain some CSF through ventriculostomy. You can think about using mannitol or hypertonic saline for the shift of like excess water out of the brain and going, taking it out. Think about sedation. Hyperventilation is an option, but you need to be careful with it. You really need to be careful with hyperventilation. And this goes all the way to like barbiturate therapy, decompressive craniectomy, or hypothermia. Hibernal therapy cannot be commonly done everywhere because it's very complex, but it's an option. And thank you.
Okay, Ulrich, fantastic. You're beyond your level of training, really, to give a presentation like that. Okay, Khalif, would you like to make some comments on Ulrich's talk? Are you there, Khalif? Well, one comment I'd like to make, Sydney, Ulrich, before we start is is I'm not a neurosurgeon, but I know that as an emergency physician, I was faced with some patients, and obviously in coma. And you have to know more than just neurology and neurosurgery to diagnose problems. I can remember one particular patient that we saw that came in hemiplegic, and they immediately called the neurosurgeons, but it turned out that this patient had diabetic ketoacidosis that presented like a stroke, and it fooled everybody. It fooled everybody. They almost brought him to the OR. So a neurosurgeon has to know other areas of medicine besides the nervous system. Are you there, Khalif?
Um, so, so yeah, I mean, you're absolutely right, John, because this is why we insist on this, and it's even more important for those of us that will be working in low resource settings. So we don't always have all the human resource you're going to get in the high income country. So what will happen is, soon as a patient is said to have a coma, if they say, if you are in a hospital and they say it's a coma, the first thing they do is either they call a neurosurgeon if he's around, or they call a neurologist. So you, as a neurosurgeon or neurologist, like John said, you don't want to find yourself taking a patient to the OR for something that could have been treated with just an IV access, right? A simple IV access and getting fluids to the patient or getting drugs to the patient. You really want to be careful with that. Coma is not automatically neurological or neurosurgical. It's a wide, very big, very big pot in which everything and anything can find itself. So once again, how do you make the difference? Your clinical examination. And talking about that, I just want to share this, John. There are a few websites I think we can use, because I find that they're free, so very interesting. You can see this one, neuroexam.com. You should visit this. You have the neurological examination, very interesting. You can go to neurological cases as well, free. So good websites. And another one I would advise is eBrain. eBrain is a website by British, like the UK, residents from neurology and neurosurgery residents. So they have, you can register for free. Normally you'd pay, but when you're from a low and middle income country, you can register for free. So you have all these courses you can take, all these courses for free, and they're wonderful. So do them, take them, and you can take like exams, which are the same level for those who are doing their residency in the UK. So definitely do it. It's not very expensive.
Yeah, that particular patient I mentioned, they were ready to take him to the OR. And it's only because of routine blood screening that they picked up the very high, astronomically high sugar. It was almost 800. And they said, whoa, wait a minute, don't bring him to the OR. It's not a subdural or any other neurosurgical emergency. It's a medical problem. So yeah, a neurosurgeon has to be pretty well rounded in other areas of medicine. So, okay, any other comments or questions from the panel for Ulrich? I think everyone's sleeping today.
We are very much awake, John. Thank you for the
Okay,
presentation.
very good. Okay, Khalif, thank you.
Yeah, thank you for the presentation. I just wanted to add on the Glasgow Coma scale. It is a tool that we communicate all over the world, and it's pretty important that everybody understands it. It's very basic, but sometimes you can be confused a little bit. So it's an input-output system. So if you find that a patient, for example, a patient is in coma, so would you score that as 4, or what do you score that, Sydney?
So
Just walk in, there's a patient in the ICU bed,
Yes.
His eyes are open. This patient is not blinking. There's nothing, but his eyes are open.
So, what I'll do? You said eyes are open and he's not blinking,
The
right?
eyes are just open, like, yeah.
So you still need the, I wouldn't score it immediately from like the eye opening. I still need the verbal and the motor. So
Yes. But then it's an EVM thing. So the eye,
yeah.
it's out of 4. The lowest you can score is 1. So in that case, how do you score it? It's you score 4 or do you score 3, 2, 1? Basically, what I'm saying is that these patients, sometimes you score them 4, but they just have a blank stare. They've got a point on the lesion and they're not blinking. So you can walk into an ICU and they say, oh, this patient has spontaneous eye opening, and you give them a score of 4, probably give them a V of 1 and an M of 1. That already distorted your GCS. So it's actually a very important thing to understand. The original paper was written in the 1960s. We can, not 1960s, 1980s or late 90s, early 90s. That's when it's written. The original, was it 40s or 60s? So it was written a while back. Anyway, 40 years ago. Yeah, it was written 40 years ago, and at that time, nothing much has changed since then. Before that, people were confused on what to use to grade patients in coma. Some people want to use the mini mental exam. Others wanted to use motor power. Others wanted to use some different scales. So the GCS is a standard scale, and it's for this topic that you are discussing today of coma. It's actually the most important thing. So the GCS is the way we communicate. If you say a patient has a GCS of 3, that is different from a patient with a GCS of 9 in terms of prognosis and even the level of care that they need. Yeah. But thank you for the excellent presentation. And the website that you shared, even though I can't find out why this one is not working, the neuroexam.com.
Well, I will just share the links. So thank you so much, Dr. Khalif. Actually, there's even a very good publication that was made really recently about the 40 years of the Glasgow Coma scale. I've just sent the link in the group. So guys, please check it out. I'm sure it's very nice. You like it. Let me send the neuro exam link.
Okay.
Yeah. So yeah. So the neuro exam link.
You have to. Oh, you have to register, right?
For
the website to get an access.
So eBrain, you have to register. Well, they're free, so it's okay.
eBrain I have registered it last year, but there's an exam that I wanted to do, and then when that time was over, they closed.
Oh,
I don't think it's completely free. Yeah. Okay.
Zolo, do you have a question, comments? No, as comment, I would just like to say thank you very much for the presentation. It was quite comprehensive, and from all the discussions you've had, I think the importance of the GCS has been made clear, and I think it's really important because the main tool I knew about when we have to monitor a patient in coma. So thank you again for the discussion we had. Sorry, my network was really poor and I could not enjoy all the presentation. But if possible, I don't know, is it possible that during this new series of lectures we have, can we be sharing the PowerPoints in the
definitely
surgical TV group? I don't.
Okay, yeah, that's a good idea actually. We'll share it. So
all right.
Thanks. So John, for next week, what we're going to do is we'll be presenting. It will be a 2-for-1. It will be Zolo and myself. So Zolo will be talking about intracranial pressure monitoring, and I'll be presenting on invasive multi-modality brain monitoring, because those two go together. So there's going to be a lot of physiology, neurophysiology. So I think it'll be interesting.
Oh, great. I just have a question from Khalif. When you come into the emergency room and you're called to see a patient that's in a coma, could you describe, and this is more or less aimed at students, what basic exam do you do? Exactly what do you do? And how long does it take for you to more or less have a good idea of what's going on? How long does it take you by the time you hit the bedside? And what exactly do you do in the physical exam?
Exactly. Okay, that's a very good point. So it's usually an emergency setting. You're called into the ER, into the emergency room, and then there's a patient lying there. It's usually very difficult to get a proper history. Is he drunk? Was he hit by something? Is he alcoholic? Is he a diabetic patient with DK? You have no idea. So, and usually it probably is brought by passers-by who just found him along the road, or he was brought by a family member who's also in distress that can give you proper history. So the first thing you need to get is to, the way I was just saying, to get the GCS. Is this patient in dire danger? Okay, so you get a quick assessment of the level of consciousness of this patient. Then, before you do anything else, is to go with the ATLS protocol. The way someone's audio is too loud here. So yeah, so if you start with the ABCD, assess the patient's airway and breathing, C-spine, airway and C-spine, breathing and circulation, and then GCS. Then from there on, coming to our topic now, patients can be different. They can be a gynecological patient with bleeding of some sort or something else. But if it's a neuro patient, your most important thing is to assess the GCS, and that's where our interest lies. Yes, so you assess the GCS. If the patient GCS is less than 10, that patient needs to get intubated, most likely. These are patients who cannot protect their airway, they'll aspirate. So you need to get an urgent intubation, then transfer them to the ICU. And then you investigate the basic causes of this. You just start with normal blood pressure. Is it too high? Is it too low? Then random blood sugar to find out is sugar. Is it too low? Is it too high? You know, basic electrolytes, full hemogram, or yeah, you know. Those now will guide you on what to do next. If, of course, you can get some history. This patient was knocked by a car, suspect a head injury, a plan for a CT scan. Probably the patient has an expanding hematoma that needs to be evacuated. So your decisions actually will be judged by, you know, systematically. What you do, one thing leads to another thing. One thing leads to another thing. Yes. So that's how you go around it. But start from the basics. ATLS protocol, GCS, and then investigate. Start on the basics. If you can get some history, well and good. If you can't, then you have to figure out what exactly is causing these patients. But if you go with ATLS and GCS and the patient is intubated, almost always you have done the right thing.
Mm-hmm. Thank you. Very good.
Anything you want to add, Sydney?
So yeah, thanks, John. That's a very good question, and thanks, Dr. Khalif. I was saying, for a student, there's another link like YouTube on the really practical thing to do, and that's what Dr. Khalif said. So as soon as you get in, there's one really small thing, one very small way of going through it is you call out the patient, right? If he can respond, like Mr. This, Mr. That, like trying to stimulate. That way already you're trying to get information about does he open his eyes at when you call them, and then you go on with the rest of your Glasgow Coma scale. So as soon as you get there already, when you're trying to speak to the patient, you're already evaluating the patient. It has to be quick, like I said, and although we describe all these things, and it will be long for you when you start, but then the more you do it, the more you become versed with it, and it doesn't take you that long actually. These are all processes that go on. Dr. Khalif, you're muted. You're muted.
Yeah, Sydney, sorry, if you can show me that slide of the GCS just to go through a little bit on
Oh,
how
okay.
to assess it. It was on one of the first slides.
Please. So
just to go through on how to do the GCS. Interestingly, we had presented on
yeah.
forum just the other day.
Is that okay?
Yes, sir. That's the correct one. Yeah. So I like the way you arrange it. It's EVM. So we start with the eye, then the verbal, and then the motor. So this is something that you need to develop, because don't start like MVE or VME. Don't confuse it. You just start with EVM. So the first one is the eye, and the verbal, and then the motor. So it's 4, 5, 6, the score. The highest score you can score in the eye is 4, for verbal is 5, and for motor is 6. So in that chronological order also, it's 4, 5, 6. The least you can score is 1. But the new updated link that Sydney shared is there's a T. So you can have a 2T. That means the patient is intubated. So you cannot assess verbal. So it can happen that you can have a motor response of high, maybe 3, 4, and you're opening your eyes to pain or something, but then we can't assess your verbal. So in that case, you do V instead of giving it a number, you give it as T. So you only score for I and M. So before you go there, so how do you assess the eye opening? So you walk into the room, you try to talk to the patient. Hello, Mr. Sydney. Hello, how are you? Patient is not responding at all. His eyes are still closed. You give him a sternal rub. Then the patient does not open his eyes. His eyes are still closed. You give him a pinch on the bed, the nail bed. Then there is no response. So that's a patient who's unresponsive completely in terms of eye. So you give him a score of 1. Okay. So you have to also be aware that if the patient has severe edema, the patient has facial injuries, and they can't open their eyes, then you try to give them a sternal rub of a painful stimuli, and there's no response. It might be it's because of the edema, so you have to be careful with that as well. Okay. So, and as we said, this test it depends on it's a responsive test. It's not, you just don't gauge it. If you see somebody moving their hand up and down, it doesn't mean anything. It has to be an input, processing system, which is the brain, and then the output, which is the muscle or verbal or whatever that is going to happen. So if I find you in the ICU, I was just talking to Sydney about it, and the eyes are open, but then you're not blinking, or you're not staring, or you're not taking any input from the environment around you, then that is not a responsive eye opening. It's not spontaneous. So what does I4 means? This means that you walk into the ICU room, the patient's eyes are open, they're able to look at the sides, they're able to blink. That patient has a spontaneous eye opening, and you give them a score of 4. The patient's eyes are closed, you call their name, they open their eyes, you give them a score of 3. You give them pain stimuli, you give them a sternal rub or nail bed pinch, or at the orbital rim, and the patient opens their eyes, then that starts opening eyes to pain. So you give them a score of 2. If the patient is completely unresponsive, you're cutting their leg with a saw and they don't respond, then that's a score of 1. That's how you go about the eye opening thing. I just want to be very clear with one thing. If you just find the patient is staring blankly, does not mean that that patient has spontaneous eye opening. You can't score them at 4. So coming to the verbal, what does it mean, a verbal of 1? A verbal of 1 means the patient is not responding to any stimuli. And in this case, the stimuli is only 2 things, either verbal or pain. So let's start with the worst one. You give the patient a sternal rub or a painful stimuli, the patient does not at all give a response, then you score them 1. If you give them a painful stimuli, give them a sternal rub or a pinch at their nail bed, and they make a groan, like sounding like or ooh or something like that. No words. You can't make anything out of it. It's just growing. Then that patient gets a score of 2. If when you give the patient a painful stimuli, or they make a word like leave or stop it or something, or at least a word that you can understand in any language, then that is incomprehensible. Sorry. So the incomprehensible sound is the groaning, which is 2. Inappropriate word is the patient just says a word but does not mean anything to you, but there is a word that is formed, and you give them a score of 3. Then you ask the patient about what time it is today, and then they'll tell you their name. As a patient who's confused, so you give them a 4. Okay. So, and then if the patient, you're able to have a conversation with, how are you doing, where is this, what is the day today, the date, the time, and the patient who's oriented, so you give them a score of 5. So you walk into the room, you greet the patient, they are responding to you, how are you doing today, what's the date today, oh, today is Saturday, I'm doing well, where is this hospital, I'm in this hospital, what is your problem, I have a headache. This is someone who you can have a conversation with. That is 5. Patient who's confused, you give them instructions, please lift up your hand, they can't do anything. Sorry, that's something I'm digressing. You're trying to have a conversation with them, but they're talking, but you cannot understand. So you're not getting them, and they're not getting you. That's a patient who's confused, they get a score of 4. If the patient is making a word like yes, no, but inappropriate, it does not mean anything to you, they get a score of 3. If the patient is just making sound like or they're groaning, then you get a score of 2. If there's no response at all, the patient gets a 1. Coming to the motor response, which is actually a very important response because it's the most prognosticable part of this, is patient obeying command is 6. You walk into the room, please lift up your right hand. Patient lifts up their right hand, they get a score of 6. If the patient is given a painful stimuli, maybe you want to pinch their nail bed and they move away from it. Okay, sorry. If you're giving them a painful stimuli and then they take it out, that is localizing pain. Or you give them a sternal rub, and the patient's hand comes and then takes you away. That is a localizing pain. Patient means that patient knows where the pain is and they're localizing it, and they're moving the painful stimuli away from their body. That patient gets a 5. If you get a pinch, okay, and the patient moves away from that side, but they don't actually try to remove it, then they get a withdrawal from pain, which is 4. If when you give a painful stimulus to the patient flexes, okay, flexes, and usually it's the upper limbs that you need to look for, is that they flex their elbows and the wrist is always like this, then that patient gets 3, flexion to pain. It's also called decorticate posture. In this case, it means the lesion is above the red nucleus. Am I right, Sydney? Which means the input from the cortex is not getting into the lower limbs, into the rest of the body. So in that case, yes, in that case it's flexion to pain. Okay, then worse than that is extension to pain. The patient is like this, and the upper limbs are extended. Okay, so that patient gets a 2. If there is no response at all, it's a 1. Please remember that the pupillary examination is not part of this. Yeah. It's not part of the GCS. Mm-hmm. Yeah. Thank you very much.
Thanks, Dr. Khalif.
Going back again to the physical exam, Khalif, do you typically do a corneal reflex on a patient, or is that kind of is not something you typically do on a comatose patient?
Okay, for the corneal reflex, yeah. Okay.
Do you think that's important and
so basic? The corneal reflex and yeah. So in that case, it's patients who you suspect are brain dead, and you want to do a brain function test, brainstem function test. For those patients now, you can do the brainstem function test, in which you do some of the cranial nerve examination, and part of that is the corneal reflex, in which you put a small cotton onto the white part of the eye, the sclera, and then if the patient blinks, then that means that the patient has a corneal reflex, which means the third nerve is functioning.
And the reflex
Yeah.
hammer, do you use the reflex hammer a lot in the basic screening comatose patient?
For the general neurological examination, when you want to do a reflex exam, the deep tendon reflex exam, that is part of it. But for a coma patient, remember the most important thing is the GCS. And after that, if you want to do a full neurological examination, then you do the standard way. You start with the cranial nerves, then sensation, then motor, then sensory. And I think, John, that's a very important topic. And we might be able to do a presentation on that, on how to do a neurological examination, head to toe. I think that's a very, very interesting topic. That will be, yeah, that's something that we need to look into. But it's a detailed examination. It takes not less than 30 minutes if you want to do it thoroughly. So that's for the general patient, the patient who you meet in the clinic who has got a brain lesion or a spinal lesion, and then you want to do a general neurological examination. For the patient who's in coma, your most basic examination is the GCS. Yes.
Thank you. Okay, very good. Any more comments or questions from any of the panelists? Igor, are you there? Igor, can you hear us okay? Perhaps not. Okay, anyways, Ulrich, thank you very much, and we look forward to the double shot next week. And this video will be on the playlist of neurosurgical emergencies that will be available on the smartphone. You'll be able to easily see the series. This will be the number one. This is number one in the series of neurosurgical emergencies. And thanks everybody for coming. And thanks
so
a
much,
lot.
John.
Yeah,
Safe
thank you,
flight
everybody.
to
Thank you.
Miami.
Thanks,
Bye.
Solo.
Bye, girl.
Okay, we'll stop recording. Thank you.